Following is a conversation with Dr Gianluca Ianiro, practicing gastroenterologist and clinician scientist based in the A. Gemelli University Hospital in Rome. Dr Ianiro is a leader in the application of fecal microbiota transplantation, also known as intestinal microbiota transfer, as a therapeutic modality in patients with digestive diseases. This is Inside Matters. My name is Dr. James McElroy. I hope you enjoy it. We'll get you some water, my friend. You enjoying Scotland?
Yeah.
Yeah?
Yeah, it's...
Any whiskey yet?
No, still not.
Tonight, I'm sure.
Yeah, tonight you will be at the...
I will be there, yeah.
Okay, great.
So we can have a whiskey tonight.
Yeah, and I will... so we can discuss even with Francesco, with the Nicola Fellow.
Yes, let's definitely do that. Yes, of course, because he was speaking yesterday. I'm looking forward to it.
And basically...
Well, Richard Hansen they were drinking last night with Morgan Langell.
Uh-huh.
He said, James, you come here. I said, no, I can't. I'm just worried that they're going to be having lots of whiskey. And I can't have a lot of whiskey. I just feel bad the next day.
Yeah.
Low tolerance.
No, but the atmosphere was incredible.
Last night?
No. Today. In the afternoon. You know, I was in the restaurant of the hotel.
Yes.
The radio played Don't You Want Me, Don't You Want Me, baby. It's a typical English,
Oh, gosh.
a typical English song of the 80s.
Yeah.
And so with dark electronic pop.
Yeah.
And
everyone was dancing.
In the screen, the BBC with the notice about the Queen.
Yeah.
And I was eating an omelette. So it was so English, so British. And I say, wow.
Oh, man. I'm glad you're having a good time. But bringing us to microbiota, tell me about your journey into the field.
Oh, I come from a school that has been always into probiotics and before into bugs, because my school at the Cattolic University, school of Professor Gasparini, was into Helicobacter. He's one of the first that was into Helicobacter pylori. And after Professor Antonio Gasparini started his interest in microbiota and probiotics. But at that time, the people who were into microbiota and probiotics were considered a kind of freaks because there were no big data, there were no big papers. So basically, it was difficult to follow this field.
Right.
But I remember that there was a paper in gastroenterology. There was not such a complex paper. It was a 79-patient retrospective cohort from Finland, from Iiro Mattila. Patient with Clostridium difficile infection treated with the FMT. And I remember that I was with my mentor, that was Giovanni Camarota, that you have known.
I have met him.
You have met. And he said, I was a trainee at the first year of training, of postgraduate training in gastro. And he said, look, we have to do this. This is the future.
Oh, okay.
Yes.
What year was this, roughly?
Sorry?
What year was this, roughly?
It was 2012.
Yeah.
Or 13, I don't remember. So it was 10 years ago, basically.
Right.
And, I was surprised because I had in my mind, my pathway was totally different before this, because I said I want to become an endoscopist, an advanced endoscopist, go abroad to learn a technique and come and do this. But then I realized I had an opportunity, a kind of bet to do. And I was just betting on this. And instead of going abroad, I decided that I had to stay in my unit, in my place, to help building this FMT center, we started as anyone that wants to approach a kind of field. You start publishing a review article. It's a kind of you start publishing a review article and then building some data to publish them original papers. But in the meanwhile, you can start some review article.
Right.
And we published a systematic review because I was also into systematic review meta-analysis. And
what is that, just for the listener?
A systematic review basically is a kind of review of the literature when you systematically search all the terms that are close to the field that you want to get in. And then you collect all the data. So if you find 10, 15, 30 studies, you say, we have 30 studies. One is from UK, one is from Italy, and blah, blah, blah. We have a total of 100 patients, and so on. So it's a description of what is published, but very systematically. Right. So it's a very good power also on a methodological point of view.
Got it.
And
you sift out all the papers that are not relevant and that don't meet the criteria.
Yes.
So you've got a group of papers that meet an a priori set of parameters, essentially.
Exactly.
Yeah.
And it was really cited. It was probably my most cited paper.
Really?
Yeah, it has more than 300 or 400 citations, I don't remember.
Yeah.
And it wasn't published in a big journal. It was a journal of 3 impact factor at that time. Right. But it was really one of my most successful paper.
Wow.
And then, meanwhile, we had also a kind of we built the FMT story. So with the collaboration of our microbiologists that were really keen on doing it. And this is a tip that I tell for whoever wants to build an FMT center. You should have a microbiologist who's supportive.
Gastroenterologist, microbiologist, maybe an infectious disease doctor.
Yeah, But then I will also tell you, we have also built a pathway, a clinical pathway for Clostridium difficile, and we are included together with the infectious disease specialist. So right. We have a multidisciplinary decision on who should do the FMT, who should do the antibiotic therapy every time.
Got it.
So it's really, really important to have all these figures together. You cannot do anything just alone.
Got it.
And, we published the first randomized controlled trial of FMT by colonoscopy versus vancomycin to cure the Clostridioides. And it was also really appreciated. It has a lot of citation. It was a milestone paper.
The AP&T.
Exactly, yes. The AP&T paper.
Yes.
And then after that, we moved also, as we got a lot of requests from other hospitals, we moved to the frozen material, to using frozen material that as there were some papers that popped out and show how to do it.
Right.
And especially
from the US, right?
The US, but also from Finland.
Okay. So Finland and the US were pioneering the methods of preparation during the early days?
Exactly. It isn't so difficult. It's easy to do it. So basically, it was easy for our microbiologists to follow us in this project.
Right.
And finally, we participated then to several congresses. I remember that I was started with presenting my FMT papers, FMT projects as posters of abstract at the UEGW. And then we'd invited talks as well. on FMT.
For C.diff at this point, right?
At that point, as C.diff, but I will tell you later the story.
Yes, yes.
Then I think that the apex of this C.diff story, we did it with the two main achievements. One was the launch of the consensus projects for FMT in clinical practice. We were able to gather a lot of experts from Europe, the first one, and on the stool banks after 2 years. And we had a lot of international experts that became friends. Right. And
first conference was in Rome.
Yeah, right? Yes, exactly.
Yeah, I remember.
Remember.
I remember. Yeah.
And we were also, and we also established a lot of collaboration, specifically with the most of them. And this was something that made the FMT be really widespread. Then the other is an original paper that was published in Annals of Internal Medicine that showed that FMT is more effective than vancomycin in preventing the complication of Clostridium, including the bloodstream infection, death, and also the length of stay.
What's your hypothesis around that? What's going on? Why does it make... So not only is it preventing the infection with C.diff, right? So patients have C.diff, nasty infection, lots of bowel movements, fever, diarrhea, dehydration, sometimes toxic megacolon, where
yes.
Death, sometimes colectomy.
Yes.
The vancomycin sort of suppresses the C.diff, but it doesn't change the rest of the ecosystem in a positive way. And sometimes patients within 8 weeks relapse. So they get another infection or they become reinfected with the same strain. But the FMT seems to prevent them from getting reinfected, right? So that's well established. Yeah. But what you showed was not only does it prevent them being reinfected or sort of relapsing, with the same strain, there's other benefits. So bloodstream infections, death, so on. What's going on there? What's your thinking?
My feeling is that restoring a healthy microbiome increases. There are two reasons. One is the biological reason. So restoring a healthy microbiome reduces the inflammation, reduces the risk of translocation of other bacteria or fragments, and reduces the length of stay, accelerates the process. So basically, it decreases the likelihood of death from any cause. The other is a kind of clinical, because if you cure Clostridium before the patient gets out of the hospital, or even does not arrive to be inpatient, to hospitalized. And hospitalization for these fragile people, it's really risky because they can contract new infection, they can have, they can be embedded, the embedded syndrome. So basically, this is another reason. So these are two reasons.
Makes sense. So after that publication then, what happened?
Oh, well, I have personally understood that, the Clostridium difficile was just a story, but there were a lot of chances, a lot of opportunities, and a lot of also of fun. And I highlight the word fun because I have really fun in doing my job. Otherwise, I would not do just, for surviving. Right. But I do it because it's a passion.
Yeah.
To me.
I've always been able to tell that. It's infectious.
Well, and I said, okay, we have to move outside the C.diff. And I started to assess FMT in other kind of indications. I was lucky to win a grant from the Italian Ministry of Health for a randomized trial on FMT to improve the response to immune checkpoint inhibitors in renal cell carcinoma.
So these immune checkpoint inhibitors, for the listener, are...
immune checkpoint inhibitors have some drugs that are able to, if work, they control the tumor by modulating the immune system of the host. So it means it is a breakthrough in medicine because they move the cancer from a life-threatening disease to a chronic disease if they work.
Wow.
Because there are people that go to take immunotherapy as biological therapy for rheumatoid arthritis or for Crohn's disease. So it means you can think about how is important that this drug work.
Right. Right. And some patients take them and they have advanced cancer. It's all over the body. They can take them and then it disappears. Some small number.
If they work, with a complete response, or they can have also a stable disease, which is a partial response,
right? Which
is still okay,
still good, right? Yeah.
But I mean, this is really important. And while preparing this grant, we had also another achievement. We studied the efficacy of FMT in another randomized trial for the diarrhea that came up after the tyrosine kinase inhibitors.
Another cancer drug, right?
Another cancer drug. You know, these drugs can give diarrhea as a main side effect. And some people, a considerable part of people, even 40-50%, have to block totally or have to interrupt temporarily the drug because of this. So think about in their natural history of their fight against cancer, how it can be treatful.
Right. Absolutely. So they stop taking the drug.
Yeah. While we discovered that FMT is significantly, and for the audience, significantly means that is statistically significant, significantly more effective than placebo in curing, in resolving or at least reducing to a tolerable amount the diarrhea for up to 2 months after the transplant.
Wow.
And it was important to me, I mean, because it was my first paper of FMT outside the Clostridium, and it was my first big paper in a translational journal, which is Nature Communication.
High impact journal, right?
Yeah.
So the findings with tyrosine kinase and FMT, was that a surprise to the research group? And also, how might that impact on cancer patients around the world?
I think that this should be. It was nice because we had a kind of a huge response similar to that of C.diff. So it means that this can be a kind of disease where a healthy biomass can work. While we will see that other disorder, we need a more precise, more targeted microbiome-based therapy.
We'll definitely talk about precision. Yeah. I just want to come back to the tyrosine kinase diarrhea a little bit. So in the C.diff story, it sounds like people became aware of the fact that it was really effective at preventing recurrences of infection. And then some of your work has shown that actually there's other benefits. It's not just prevention of recurrence of infection, there's other wider bodily benefits. Is that the same in the tyrosine kinase inhibitor story? Are there, in addition to stopping diarrhea and therefore improving adherence to the treatment regimen. Do you think that there's other wider benefits? And if so, like, have we proven any at this point in time?
Yeah, we had, it was also significant difference between those who stopped or suspended the therapy and those who not.
Wow. Okay. So should all patients taking tyrosine kinase inhibitors have FMT?
We have also to discuss, because no one has already done it, if they own microbiota before of the chemotherapy.
Right.
So an autologous FMT can be useful.
Interesting. What's the thinking there? The tyrosine kinase inhibitors damage the microbiota and then they get diarrhea? Or
we know that all the chemotherapeutics, but also the radiotherapy, influence the microbiota by increasing the pro-inflammatory species, for example, Enterobacteriaceae, and decrease several short-chain fatty acid producer, Akkermansia, lactobacilli, bifidobacteria, and so on, which are all beneficial bacteria. So, I mean, this can be the mechanistic mediator of mucositis that gives diarrhea.
Wow. Also in radiotherapy?
Also radiotherapy.
Because this is a big problem, right?
Yeah.
I used to work in the children's hospital.
Yeah, I remember.
Some kids had really bad sort of radiation-induced problems.
Yeah, but think about it. The radiation burns the cells with the fastest turnover, which are the intestinal cells. There is no mucus, so also the
bugs start eating the intestine.
Exactly.
Yeah, because the bugs love mucin.
Yes.
Mucin's a prebiotic.
Yes.
Right? So they get very happy there.
Yes.
And if there's no mucin to eat, then they start burrowing their way into, I guess, the epithelium, right?
Exactly.
And you probably, as you say, get a shift towards bugs which are more efficient at eating the epithelium rather than the mucus. So it gets worse and worse and worse. So what we're saying here is, well, these are known effects of radiation and chemo, but we can maybe make them better or reduce the effects through either giving someone an FMT from a healthy donor, the allogeneic, or, as you've just touched on, banking their material before the treatment.
I think that...
is that the future?
I don't know. It can be tricky, but that could be an option.
Yeah. So is your group doing some work on the autologous at the moment?
We have some plans about this.
Very interesting. Good. So on immunotherapy then, what have we seen as a field?
We have discovered that there are several papers out that some microbial signature are associated with response or with the loss of response to immunotherapy. And this is why, because the microbiota is a huge influencer of the immune system, and this is why it happens. So the story is, and this was also supported by my studies, if I give an FMT from a responder to immunotherapy, what will happen to the patient, the recipient, who does not respond?
They get better, or in some cases, they respond.
I still don't know, because this is I'm running a double-blind randomized trial, so I still don't know.
But the studies that have been published to date have been quite compelling.
Yeah, there are a couple of studies published very well in Science, both in Science, and show this.
Yeah. So the question is, in those studies, they took microbiome material from the responders and
long-term responder.
Got it. And they moved them into the non-responders. So I think the question we all have is, does it need to be microbiomes from a responder, or can it be microbiomes from a healthy, unrelated donor? Because there's something feels not quite right about moving microbiome from someone who has cancer, because that's a problem that could be microbiome mediated, into someone else.
Well,
do you see what I'm saying?
Yeah, this is a tricky issue, but I can say that you can be healthy and have not that profile.
Ah, well, let's touch on that then. I find that fascinating.
You can even be, you can be a responder, but this may happen for some other reasons. But basically, in the guideline, we excluded the people with the gastrointestinal cancers, not with other cancers.
Really? That's what the consensus...
In the first consensus, it was that way.
Ah. So would you accept a donor if they had a cancer?
Actually, we are not accepting for the common practice.
Yes.
But for this specific trial we are doing, because there are already, a couple of papers published very well that show the effectiveness on this.
Yeah, I understand that. I find it difficult to figure out how we would scale a product in which the material had to be collected from patients who'd sustained response to immunotherapy. Do you get where I'm coming from?
Yes, but I believe that in the future, and that we will discuss about this, for sure. But in the future, we won't accept any more feces from donors.
We'll definitely talk about that, because I don't think I agree with you. Maybe one day. But I think I'll have a lot more grey hair in my head.
Yes, absolutely.
I might be, I don't know, walking. No, I won't be walking with a stick, so I'll still be going to the gym. But yeah. I'll be much older. So coming back then, before we go to the future, and can you tell us a little bit more about the consensus guidelines, and what are they, and how difficult are they to put together, and what are the criteria, what are their purpose? So
basically, when you establish a consensus guideline, first of all, you establish a kind of a steering committee, and to decide which are the experts that you should involve. And they are basically taken by cooptation, because you need some people who are expert in the field. Some other society, and you should have the support of a society or at least of a interest group. Then you can even launch a call for experts, as some societies do, and then you have to review the CV of the candidate to see if they fit the expertise that you need. Then you have to divide. Usually we prepared an outline of a structure of the consensus with the questions that should be addressed. And depending on the topic, you can apply a specific methodology, for example, to define the strength of evidence and the quality of the recommendation.
Yes,
which is the grade system is the most commonly used.
Yep.
But it's a kind of it's a lot of work, because you have also to then define the questions, then divide the people in working group, assign a leader to each working group, and then usually I let the working group work alone. So they work on their own we give a time to work and to produce statements and supporting comments and evidence. Then I gathered all together that kind of findings, that kind of material, and started the Delphi process. The Delphi process is a kind of process to achieve the consensus. And it means that everyone should read the initial draft, and agree. For each statement, you have to agree. And if you don't agree, you have to explain why. So, if at least the 80% of the people agree with that statement, the statement passes.
Got it.
If there is less than 80%, so you have to change according to the suggestion of the who did not agree, and send back to all the people again until you don't achieve the consensus for the all statements. You can even discard some statements, as we did, to, because most of the people were not agreed with them.
And this process, is this used for many consensus guidelines that are published, and they inform the field around what they should do and what they should do beyond FMT? I'm talking about now.
Yeah, basically you can use
method.
you can use a standard method on every consensus conference.
Got it. And how have the recommendations changed? How's the field changed between the first and second consensus guidelines? And what are we going to see next?
Basically, in the first one, we opened to the frozen material.
So you move from fresh to frozen?
Yes, we just opened to the potential, but we were basically in the second consensus about the stool banking. It was completely different, as we dealt mainly with the logistic and organizational aspects, while the donor screening was more or less the same, and the route of delivery were more or less the same. We gave more strength to the frozen material and to capsules.
Yeah.
But, there were two different aspects of the same story.
So you mentioned capsules. Do you think that eventually we will only do capsules, or do you still see benefit in going up the back passage with the colonoscopy or the enema?
For patients with C.diff, it's a benefit because you can see if there are some pseudomembrane that you use as a marker of healing. If you cure the pseudomembrane, you can stop the FMTs.
Right. So in some cases, it's still worthwhile to do the colonoscopy.
Yeah.
Any other indications?
Well, probably I would do it at the start of a FMT session.
Right.
Of infusion, probably.
To have a look at what's going on.
Yes.
So is there a difference in effectiveness if you deliver to the upper GI tract versus the lower GI tract?
Well, if you compare capsule and colonoscopy, basically it is the same.
In C.diff? But it might be different in other areas, right?
Probably.
So,
even because of the compliance, because you can repeat more easily the infusions.
Yeah. Should we talk about ulcerative colitis?
Yeah.
So where are we right now with microbiome in ulcerative colitis, form of inflammatory bowel disease?
I think we were a bit stuck until a few years ago, because we had several papers that showed more or less the same story, so that it works in 1 of 3 people.
1 out of 3 people?
1 of 3 people, so 25, 30%, 1 of 3, 4 people. But that basically we didn't know which was the right protocol, because all the protocol was different.
Very different, right?
Very different. And they had also... and it was another point, which is a cultural shift. It came out a couple of papers published in one in the Lancet Gastroenterology Pathology, which is the
Param Sothe.
Yeah, but it's the Lotus trial, I think it's called.
That's just come out very recently, right?
Yeah. And it is nice for 2 reasons. First, they used preconditioning antibiotics to prepare the microbiome engraftment.
We need to talk about engraftment. I'm going to make a note.
Yeah. And the other point is that they used FMT in capsules for a long term. And they assessed also not only the induction of remission, but also the maintenance of remission.
Right. So the studies before the Lotus, and we'll get on to Lotus.
And in another paper published just in Gut, they showed which were the microbial determinants of success.
Well, that's very, very interesting and very important potentially for future improvements to the treatment. But going back a step before the Lotus, all the studies were showing 1 in 3. Was that an induction of remission or induction and maintenance? Like, what was it in terms of the data?
Basically, they reached both outcomes.
That's great.
Yeah.
That's
This
great.
is great because it's a cultural shift, because it means that you don't have to consider FMT just a kind of magic pill.
Right.
That you have one shot and that's enough.
You need more than one.
You need to consider it as a chronic treatment for chronic disorders. Would you ever treat the Crohn's disease with just one bout of biological therapy? No. Would you treat hypertension with just one cycle of furosemide? No. Would you treat diabetes just with the one cycle of insulin? No. So why should you do with the FMT?
Well,
this is a really common sense practice.
Well, let's just discuss this. So I'll push back on you a little bit, and I'll say the following: if the microorganisms from the FMT stay in the gut after FMT, and they produce short-chain fatty acids, and maybe they are involved in bile acid metabolism, and they produce some other things that we haven't characterized, and they stay there, and these chemical factories are just going all the time, then maybe you don't need to give another one if they stay.
Yes, but basically, the nature of our microbiome is to keep back.
I hear you.
So basically, if you see all the engraftment studies, they show that at some point, the microbiome of the recipient comes back. It's like the empire.
Oh, man. So for the listener, engraftment means?
Engraftment means that the microbiome of the donor colonizes the gut of the recipient. It's like, imagine they are some aliens that are colonizing another planet.
Yeah. So engraftment means,
you know that there is
this is interesting.
There is a street artist called the Space Invader.
Okay.
Then he produces some mosaics of aliens which resemble bacteria. And it's very, I noticed it because in Rome, in one street, there is one application of that mosaics. And I saw it and said, okay, it's a bug.
It's a microbiome.
Yes.
I like it a lot. Any analogy to space, I'm kind of in for, I'm not going to lie. So we've talked about engraftment. How important is engraftment for the success of FMT?
I think, I'm a bit biased because it's my white whale. The engraftment is my white whale. And
you're a fan of engraftment.
Yes, I am a big fan of engraftment. And I have read that there is a blackboard in my room at the university.
Yeah.
And there is a written very big engraftment to remember what I'm searching for every day.
This is cool. Is there anything else in the blackboards like that gives you inspiration or that helps sort of keep you on the straight and narrow?
Yeah, the postcards of my daughter.
Yeah.
When she comes
That's nice.
in the office and she writes me.
That's nice.
And no, so basically, there are several findings, several reports that suggest that the engraftment are linked are related to the clinical success.
Yeah.
And
in which indications and patient populations?
We have data on metabolic syndrome. There is a Dutch paper. We have a data on another Dutch paper show it in ulcerative colitis. There is one issue that how to assess the engraftment.
Right.
We are working with the lab of Professor Segata, which is a close friend, to define it, and we established a kind of way to define engraftment, which is basically the number of species that we are able to identify them because they have a lab of computational metagenomics, so they are able to identify if the strain, not only the genus of the species, are able to transfer.
Yeah.
And as the strains are quite unique for each of us, you can really say if it is your strain that colonized me or it's my strain that has kept still on the position.
Yeah.
Okay. So you mean the engraftment can be defined as the number of species that come from the donor divided by the number of whole species that the recipient has after FMT. If the donor species are that are present are more than 50%, so there was the engraftment. If it is less than 50%, there is no engraftment.
Got it. And sometimes after FMT, IMT, there's bugs that appear that weren't in the donor material and weren't in the patient before the treatment, but have found their way in. What's that all about? They come from the environment?
I don't think so. I think that there are some people, some bugs. I think about bugs as person because basically I think that the human environment and microbe environment work as well at the same way.
They're the same.
And there are some bugs that need some other bugs to grow.
Yeah.
For example, but even in the human society, if, for example, you are a fisherman, to get money, you have someone to sell the fish.
Right.
So if you have a fish shop at the market, you can sell the fish, so you will get money, you can buy a car, so the car will be used, so you can take the fuel, so I will establish a fuel shop and so on.
And the microbes are the same.
Yeah, the microbes are the same. So probably if you see new species, maybe there are some species that can colonize by diet, but in other conditions they don't stay, they pass. And in a new condition with a healthier microbiome, they are able to grow, for example.
Got it. So if engraftment's important, how do we maximize the chances of engraftment happening?
Okay, well, the report in Science, they used as well as the Lotus trial, used a preconditioning antibiotics to do this, and this is one way. Another way is to repeat the infusions.
To do more FMT.
So the more you do it, the more material is provided. And another one is to feed the bacteria after. There is one paper published in Nature Medicine that used low fermentable fibers after FMT that were much more effective than highly fermentable fibers in ameliorating the metabolic syndrome parameters and in improving, having a good engraftment.
Wow. What's your thoughts on giving patients antibiotics before treatment if they don't need them to treat an infection?
This is okay? Why, but you can use some non-absorbable antibiotics that have almost no effect.
Yeah.
For example, the vancomycin against gram-positive, or rifaximin or neomycin against gram-negative.
But is it the rifaximin or the vancomycin or the neomycin that's having the effect, or is it the FMT?
They can prepare the environment,
right?
And probably Clostridium difficile infection works as an indication, probably also because they had a lot of antibiotics before.
Right. Well, so for ulcerative colitis then, there was also a recent published paper which did FMT and dietary manipulation.
Yes,
from
one
India.
published in without inflammatory diet.
That's right.
Anti-inflammatory diet.
I don't know what an anti-inflammatory diet is. Do you?
Yes, it's an anti-inflammatory diet. They call
it, but it's right. So it's like plants.
Yes, actually, I think it's not reproducible because they used rural donors, so with a completely different microbiome, probably. They use donors from rural areas.
Very interesting. But they might have higher diversity?
Probably.
They might have better microbiome?
Exactly.
Very, very interesting. So should we be collecting lots of material from the Amazon? They've never had antibiotics for generations. They eat, they live in the earth and the dirt.
Exactly.
So should we be collecting their stool?
But have you ever been in India?
I have not. No, but I
had.
And you had diarrhea?
I had. No, and I think that you cannot take the microbiome of a donor from the big cities because there is a lot of pollution.
Yeah.
The life is really stressful.
Yeah. But what I'm saying is, if the Amazonians have higher diversity, should we be not trying to collect as much Amazonian stool as possible? Is that the best donor material, or does it, like, it's more nuanced than that?
This would be, I think, really unethical. Unethical.
Why?
Because they have their own structure, they have their own environment.
I see what you're saying. Yes.
And
it would impact on that.
Exactly.
Yes.
But I believe that the way is to, it's a tricky because you cannot pay donors, and it is right, because otherwise you would have a lot of people that would lie about their antibiotic consuming, their sexual habits, their drug consumption, and so on.
Yeah.
Just to have the money.
And there's a heavy element of donor trust.
Yes.
Still. Same in blood.
The same in blood, exactly.
But for stool, I mean,
for stool is even higher, because if you say, I have not taken antibiotics and you have taken, there is no blood test to show it. You can see only by feces.
Right.
Maybe if you have a low diversity, but you cannot say you have taken antibiotics.
Right. Absolutely. So we rely on goodwill, good faith, altruism to get our material.
Yeah.
And I think that's the way it should be.
Yes.
Certainly within the guidelines that you've been involved in producing, it's always been the case.
Yes.
Donors must be unpaid. People might be listening to this and they might be saying, I kind of want to be a donor. But how many people out of 100 would actually qualify as a donor?
I think that there is a huge... the selection is very tough.
Tough, right?
Because you have to pass some questionnaire that basically let us discard most of the people.
Yeah.
the lab exam, and including also the COVID for the COVID, as we updated the guideline recently. We defined also the a method to check not only the donors but also the stools. And you have two ways. One is the quarantine, but another one is the molecular screening for pathogen.
Yeah.
And they check just the safety. They don't check the efficacy, or at least the reliability of the material.
Yeah. How would we check the efficacy or the?
At least if there is a good abundance, a good diversity.
Yeah.
If there is a good evenness.
Yeah.
At least with ecological parameters.
Yeah.
Then another parameter can be on taxonomical composition. If there is a huge predominance of specific bacteria, this is not possible, but the evenness would go down in that case. If there is too high presence of pro-inflammatory bacteria, if there is presence of fusobacteria which are connected to colon cancer, for example, I would rule out a donor.
But we don't do that yet, do we?
Yeah.
That's the future?
That's the future, but probably, as I said, it's impossible to have that donor and take it under a glass for all his life as a chicken or a,
I hear you. You'll never have the perfect person.
Yes. And even if you find the perfect person, the first time that the patient the donor has to take antibiotics for a pneumonia and then for a urinary infection, you have lost that.
You've lost the perfect donor.
Exactly.
So we will get onto the future. I want to bring us back to ulcerative colitis. So if 1 in 3 people with ulcerative colitis benefit from FMT, why are we not doing FMT for everyone with ulcerative colitis?
First, because all the studies have investigated the people in a specific condition, so mild to moderate ulcerative colitis. And I think that the real issue is those who need the biological therapy. So probably you mean there are some people with moderate ulcerative colitis that can benefit of FMT so that they can do FMT instead of biological therapy. And that could be interesting.
Very interesting. And biological therapy to give a better response.
Yes.
But there might be people listening to this going, I've got ulcerative colitis. I want FMT, but they can't get it. Is that because we still need to do more research?
I think that first we need some more reproducibility on this.
Some more studies.
Yes.
And those studies need to tell us how many FMTs?
I think first FMT should be, ulcerative colitis is just a model for a chronic disorder. And I think FMT can first define the duration of the therapy.
Yeah.
Another point is what you are giving to the patient.
Right.
And if what you give is acting, is being is transmitted, is colonizing, is engrafting, and is acting. Because if you put some microbial signature, but they don't attach the colon, they don't produce beneficial metabolites and so on, it's a debacle.
So there's still work to do.
Yes.
With patients. And are there lots of studies ongoing at the moment trying to figure this out?
In general,
yes.
Or in
UC in general, globally?
Yeah, in UC, I think that there are some lot of interest about the gut virome.
Oh, we've not talked about the virome.
Yes.
So what is the virome?
The virome is there are some, as there are the human viruses, there are also some viruses of the bacteria. So viruses that colonize the bacteria,
yeah,
and that they are able to fight the bacteria or to help transmitting some genetic pieces that are called the plasmids that are basically useful for the survival of the microbe.
Right.
So, and
Wow.
we know that in ulcerative colitis, the gut virome is totally deranged.
Okay. So, if the virome is deranged and the bacterial element is deranged, what are we going to do in the future? Do we give the viruses? Do we give the bacteria?
I think that...
do we give both?
I think that, I think that we should first establish the relationship between bacteriophages and basically bacteria. And we have to identify if by giving only bacteria also the virome changes. I don't know.
Does anyone know? We've not done the work yet.
No, because consortia has been not studied for the virus.
Yeah. Yeah. So we're straying into the future now. Before we get there, has there been some really pioneering FMT work in other areas that we should discuss? So we've talked about the immune checkpoint inhibitors, talked about ulcerative colitis.
We talk also about metabolic syndrome, and no, I think that these are the most relevant right now.
What about IBS?
In IBS, there is, all IBS papers are so and so. It means that the results are not brilliant. And we also published the meta-analysis with Alex Ford some years ago that confirmed it. Then another paper appeared, which is an FMT paper from the Norwegian people that selected a super donor, so a super healthy donor with a very favorable microbiome.
Yeah, I saw that paper.
Yes,
It's a super donor.
it was surprising as they had incredible effect because they had almost 90% of efficacy, which is in IBS has not been reached by any drug.
Yeah.
But
90%.
Yeah, 90%. Wow. It's
another. That's incredible, no?
That's incredible, and the even more incredible is that those people had a sustained remission.
Wow.
So my
game changer.
Yes, but I mean, okay, you have found this brilliant donor. I don't know. You put you take it at home and you make him eat well, healthy, and so on. But after, what happens?
Well, I know the paper you're talking about, and they said super donor, and then I read their criteria, and I was just like, what is it about this donor that's actually super? And I'm not sure. It
hasn't taken antibiotics almost, or just 2 or 3 antibiotics in his life. He was born by
vaginal delivery,
and breastfed.
Sure, but there's lots of donors who are like that, right?
Yes.
Because I mean, it gets back to what is a super donor. So, a super donor could be someone who donates 3 times a day. It could be someone who has a very large stool every time they donate.
Yeah.
Right? I'm playing devil's advocate, right? I mean, I don't think we as a field have actually said, look, let's all sit down and have a chat about what the best donor would be for each indication.
We still don't know.
We don't know. We should have the conversation. You can bring us to Rome and we'll do the consensus conference on the best donor.
Yes.
So let us now move to a slightly different area. What is the best diet for the microbiome?
Oh. First of all, avoid the processed foods. So avoid all the industrial things. Avoid the classical Western diet with a lot of fats and proteins and refined sugar. And increase the fibers, which doesn't mean that it is healthy for the symptoms, because most of the patient go with IBS, go for a low FODMAP diet, which is brilliant to reach the remission of symptoms, but is very bad for the microbiota because it's very poor of fibers. And the fibers are needed to let the beneficial bacteria grow.
Yeah, so when someone has a low FODMAP diet, are they essentially just suppressing the whole microbiome?
Exactly.
They're dampening it all down. It can't eat anything. So you're essentially feeding yourself.
Yes.
But you're not feeding your microbes. Yeah? So that seems counterintuitive though, right? Because everything else says eat more fiber.
Yes.
It's weird.
Yes, but in fact, what I do in my clinical practice is in some people I give a low FODMAP of a low gluten diet because they reduce the symptoms, but just temporarily. Then I put, I send them to a dietitian, and with the dietitian, with my support of pharma therapeutics, of probiotics and antibiotics and so on, I basically ask the dietitian to increase gradually the fibers.
Interesting. Love that. In Italy, I mean, I was in your clinic.
Yes.
Not as a patient, I just want to say that. I was a very keen...
As a visitor.
Very keen visitor and a student learning from you. You almost have like a microbiota clinic.
Yes.
Don't you? It's like, and it's super cool. We don't have this here in the UK. So tell me about the microbiota clinic.
Basically, it's not to see different patients, it's to see patient by a different point of view. So it means we first we use the sequencing to see what is, how the microbiota of the patient is, and we connect basically its clinical history to its microbiome.
Wow. Are they doing this anywhere else in the world, or is it mainly you're pioneering in Italy?
I think it's pioneering, but I think that there are people that are the so-called microbiome clinicians that I think that can do it. There are few people in the world, but I think that I don't know if they do it, but I'm sure that they can do it.
So how do they do it? They get the microbiome analysis, clinical history?
There is a lot of microbial reporting, microbiome testing, but we use only selected one. We have a spin-off in our unit that does this,
right?
Which is reliable.
Yeah.
And then we check we check the report, and for example, if the patient has a small intestinal bacterial overgrowth, check it by lactulose breath testing, but has a prevalence of gram-positive, you cannot use an antibiotic to fight the SIBO, an antibiotic against gram-negative.
Got it. Very interesting. So you're actually tailoring your antibiotic prescribing in this patient group. Wow.
And for example, if you have a patient with huge increase in fusobacteria and a huge drop in short-chain fatty acid producing bacteria, I give prebiotics and I eliminate completely the meat from the diet, because fusobacteria has an increased risk of colon cancer.
And does that feed off the meat?
Sorry?
Does the fuso eat the meat, or is it just...
Yeah, basically they are putrefactive bacteria. They are oral bacteria, usually. Yeah. And you can find very highly them in the mouth of the vultures.
Really?
Because they eat the putrefied meat.
Wow. Fascinating. This is so interesting for me. You mentioned probiotics in the context of the microbiota clinic and prebiotics. So should we tell listeners a little bit about what they are and what your thoughts
basically,
are? Basically,
the prebiotics, I start from probiotics. Probiotics are some bacterial strains that given in a considerable amount give a benefit to the health. And the prebiotics are basically some elements, some substances that feed the good bacteria and let them grow.
Got it. And do you use both in your clinic?
Yes.
Tell me about the probiotics then, because that's probably more controversial.
Yeah, probiotics means nothing. It's a term that means nothing, because probiotic, you can have an Escherichia coli, commensal Escherichia coli, which is a proteobacterium, and you can have a bifidobacterium, which is an actinobacteria. You can have a lactobacillus, which is a firmicutes. So there is a huge phylogenetic distance between the three of them.
Massive.
But they are under the umbrella term of probiotics, which is useless in my clinical practice.
So do you recommend probiotics to patients, or does it very specific?
Based on the strains.
Huh. So what do you recommend then for the listener on probiotics?
It depends. If you have, you know that the microbiota is very flexible. So if you give probiotics of a different phyla, you can lower the other phyla, which, for example, the proteobacteria. For example, if you have an increase in proteobacteria, what I do? In people that have diarrhea, and these are the proteobacteria, it's full of pro-inflammatory bacteria that attack the intestinal wall and destroy the mucus. So first, I use an antibiotic therapy to erase them. Most of them are gram-negative, so you can use rifaximin or neomycin or some other drugs against gram-negative. The other point, to shift the proteobacteria, you can use first Firmicutes based or Firmicutes or actinobacteria belonging to microbes, for example, lactobacilli or bifidobacteria. And you can use a prebiotic as inulin to let all the big short chain fatty acid producing Firmicutes grow. And finally, you can use some kind of beneficial Escherichia coli
to outcompete,
because you can use them to achieve a strain replacement.
Yeah,
because they compete for the same food.
Mm-hmm. I see what you're saying. This is very cutting edge. I've not spoken to anyone
obviously
else
you have to find a good and experienced dietitian that knows how to increase also the fibers in that gradually.
What you're talking about is personalized medicine.
Yes.
Isn't it? Personalized medicine in practice with the microbiome. And I think it's super cool. Should the general population be taking probiotics, in your opinion? Or should it be for specific uses?
Yeah, but I think it's for specific use. It's like to say, should general population should take antibiotics?
Right.
It's the same.
Right. So all these off the shelf, you buy in the pharmacy or supermarket, probably not worthwhile.
No.
Yeah. Also, there's so much diversity amongst the microorganisms. It's like saying, you can just take 3 types of drug, which fall under the definition of drug, but they're very different drugs. The bugs are very different. So, the future.
The future, whoa.
The future, man. Tell me.
The future has 2 words: reproducibility in time and space, and precision. Reproducibility, because you cannot think, as I told you, you cannot think about having a donor for the rest of his life, or unless you treat them as a prisoner, as in the movie of Jim Carrey, the Truman Show, is under a big
in a bubble.
Yeah, in a bubble. Yeah, you cannot take it. It's just like having someone to. It's like the Prometheus myth.
Yeah.
To let the liver grow again, and you have produced feces over and over. Right. It's not possible.
It's not going to happen.
It's like to have a chicken.
But do you not think it's possible to just get really, really, really good at finding donors who are healthy?
Yeah, but finding donors and selecting is tough and is expensive.
It's very tough.
And is expensive.
Not sure 100% agree with that one. How is it expensive?
All the exam that you have to do, all the blood and stool exam, all the,
But when you hit scale, these costs come down because you have economies of scale. But I take the point. It's hard. I totally agree with that. It's hard. And you never have a microbiome that's exactly the same. So
exactly. And this is the reproducibility.
Yeah.
And the other point of the microbiome is there is the precision.
The precision, yeah.
Maybe you can have a perfect microbiome, but you have a strain that is up, and I don't need that strain.
Right.
So probably in the future, the synthetic microbial consortia have to be considered and evaluated.
So on the consortia
are basically some gathering of specific bacteria that are grown in a synthetic artificial way.
Sure.
Starting from cultures, but then cultured in a different medium. So basically, it's as produced artificially as done for the probiotics in a more complex way. Yes, but basically done on this. And I think there should be the research on this should be implemented for the future.
The consortia don't have any viruses, but the viruses might be important.
The consortia that, at my knowledge, are studied have not viruses, but I don't know if when they go, they produce viruses.
Right.
The virome changes based on the new bacteria arriving.
I see what you're saying. I mean, for blood transfusions, we've said for a long time, we're going to be able to replicate this in a synthetic manner, but we've never been able to do it. Is there something magical potentially about the donor-derived formulation that we might just never be able to replicate? The way the ecosystem is constructed, the ecology, and maybe the fact that there's so much complexity that it just works in a way that we don't understand right now. It's possible?
I think that we will never reproduce the human part of the feces. The immune, the IgA, so the immune cells, the epithelium. I don't know how much it does work. So I mean, which is the human responsibility of the feces success in FMT?
Right.
I don't know.
But the soup that the bugs produce and the other components of the microbial ecosystem, we haven't yet fully elucidated.
No.
But we need to do that, right?
Yeah.
To get the best consortia. Okay. So define consortia. Anything else from a diagnostic perspective, dietary perspective?
I think that we have to give a cultural shift. We need the microbiome get into the mind and into the desks of clinicians. So
right.
I think that we have first to define which is the correct way to report, to do, and to report a microbiome testing in clinical practice. And we have to build evidence if it is worthy or not, if it changes and gives benefit to the common management of patients or not. And then we have to educate people to think about it. We have to make the two fields closer. So the microbiome related basic science and the clinical practice.
You're doing quite a lot of work on both areas right now, aren't you?
Yeah, and
you're doing a good job.
Yeah, and I'm happy of this.
So We've been going for over an hour.
Whoa.
Yeah. We got a conference to go back to. Just wanted to say thank you very much.
It's a pleasure to be invited to here.
Thank you, Gianluca.
And say hello to all the listeners.
Yeah. Hello to all the listeners. If they want to follow you, they can follow you on Twitter.
On Twitter, yes. It's very easy. It's just they can find my name and surname, and I will be happy to share my experiences.
Gianluca, thank you.
Thank you.
Pleasure. To learn more about the guest on today's episode, or more about the Inside Matters podcast, please visit insidematters.health. Thank you.